The views and opinions expressed in this program are those of the participants and do not necessarily reflect the views of BronxNet or the program underwriters.
Sure. So let's begin. Good evening, and thank you all for joining us for this celebration of Bronx Week and our COVID Day of Remembrance discussion. I am Marcos Crespo. I'm the Senior Vice President for Community Affairs at Montefiore Medicine. As many of you know, Bronx County alone lost over 4,500 lives to this pandemic, included our 29 of our own associates, who many of whom worked on the very front lines of this fight and sacrificed all for our patients and our community. So I think in honor of all of them and the millions we've lost around the world, we should begin with a moment of silence. Thank you. I want to thank the Office of Clinical Trials and the Institute for Clinical and Translational Research for inviting me to join you this evening and to kick off what will hopefully be an enlightening discussion for everyone. Prior to joining Montefiore, I worked in state government for 18 years, the last 11 of which I served as a member of the New York State Assembly, representing the southeast section of the Bronx. Much of my work throughout that time involved advocacy for our communities, addressing health disparities and environmental justice issues. I fought for infrastructure projects that I knew would impact the air quality that our children were exposed to, that would create more resources and programs that would improve our open spaces and parkland, all with in understanding that the health outcomes of our communities are much more than what occurs in the four walls of a clinical office or a doctor's appointment. It is really all of what is happening in our neighborhoods that affects those well-known health disparities that COVID really highlighted, what the impact of those were. We have always known that the Bronx has had to fight for every little resource we've received, that we've always been at the bottom of the totem pole, so to speak, on our fair share of those resources. But every time the Bronx has been kicked down, we have stood back up. Every time we have faced challenges, we have found a way to come together, and it has been actually the mobilization of our own communities, our advocacy groups, and our nonprofit institutions that have created the very institutions that have led to change and opportunity and advancement. But we have been reminded, it was like a blunt force instrument reminder, what COVID did to us and what it exposed. And we still have a lot of work to do. Like many of you, just before joining Montefiore last year in July, I spent much of the pandemic scared about what was happening and what it meant for me and my family and my community. I was concerned because I had no understanding of what the science was. Why did this pandemic begin? Where did COVID start? All this, the political bickering that was occurring, the misinformation that was floating around social media. I was dazed and confused and unsure of what to make of it all. What has really helped me is when I joined Montefiore, seeing and understanding what was happening in our clinical settings, understanding the science behind the work that was going on. And I got to tell you, it does give me a level of excitement to know that Montefiore and Einstein's commitment to science, innovation, and improving outcomes through clinical research that relies on community participation and engagement, and understanding that research is a pathway to medical advancement and the elimination of these health disparities. That is what I'm looking forward to. All of us need to learn our lessons from what we've been through, but more importantly, look forward to how do we change that? How do we move forward in a direction that really brings us all together to learn from each other and to change the opportunities for better health outcomes for everyone in our communities? And that is what tonight hopefully will be about. You will hear from experts in our clinical settings and our research settings. You're going to understand better the work that they do and how it impacts our neighborhoods. And anytime you ask yourself things like, well, where did that medication come from or that treatment? How do we know that those were developed for people like me? Well, the answer is Montefiore and Einstein do that every day and have done so throughout their mission and their history. We have sought to answer those questions and to deliver care in a way that is culturally sensitive to who we represent as a community. And so it is important that we all be a part of that conversation, participate in this research, and understand fundamentally why it is in our collective best interest to do this work together. So with that, I want to pass it along back to Zoe to introduce the panel and hopefully encourage each and every one of you to learn as much as you can and share this information widely so that we can improve health outcomes in our beloved borough of the Bronx.
Thank you so much, Mr. Crespo, for those words. And hello, everyone. My name is Zoe Segares, and I'm the manager of the Clinical Trials Network here at the Einstein-Montefiore Institute for Clinical and Translational Research. I'm pleased to be with you tonight, and I'll be serving as your moderator. I'm now proud to introduce our keynote speaker, Dr. Earl Chambers. And Dr. Earl Chambers is the Associate Professor and Director of Research within the Department of Family and Social Medicine here at the Albert Einstein College of Medicine. He also serves as core director of population health and health systems at the New York Regional Center for Diabetes Translation Research. Welcome, Dr. Chambers. The room is yours.
Great. Thank you very much, Zoe. I appreciate that. Okay, so good evening, everyone. I hope everyone can hear me. And I hope everyone is having a wonderful evening and your families are safe and well. This past year, dealing with the COVID-19 pandemic has been difficult. Many of our lives have changed in many different unpredictable ways. For example, in the last year, I have become a middle school remote learning teacher for my 6th and 8th grade sons, which I don't remember signing up for, but I guess we all have had to do things that we didn't sign up for this past year. But in all seriousness, at the beginning of this pandemic, so many from our Bronx communities were on the front lines, placing themselves in harm's way to deliver the services and healthcare that New Yorkers needed. We've lost many, particularly in the Bronx. And we've all had to spend this time thinking about what matters most to us. But we've come such a long way. We remember what it was like in the beginning when we didn't know as much about the virus as we do now. But we are on our way out of the tunnel. There is light shining through. It is because of your commitment to community and continued participation in the health research studies that we know as much as we do about the virus and how it is affecting us. What we learn here can help others. It's been about 5 months since the COVID-19 vaccine has been available in New York City, and to date, 46% of adults have received at least 1 dose. It's much lower in our Black and brown communities though, about 25% in the Bronx. And while we can certainly do better getting the vaccine to everyone who wants it, particularly in the Bronx, we are on our way to putting the worst of this virus behind us. And I know there is distrust of the medical community, particularly when it comes to vaccines, and with good reason. There have been many instances when scientists have taken advantage of our communities and given very little back. These concerns are very real. But I also know that vaccines are the most important way we are going to beat this virus and save lives. So please get your vaccine. But we also have to stay vigilant and continue to follow guidelines to reduce infection, like social distancing and wearing masks when appropriate, particularly with these new variants of the virus popping up. Our hearts go out to countries like India and our Indian families here in the United States that have been so deeply impacted by the second wave of infection. India is recording upwards of 300,000 new cases of this virus a day as surges in infections and new variants of the virus infect many. This is a global pandemic, and the virus does not respect country borders or social class. We are truly all in this together. But I remain hopeful that humanitarian efforts and diligence on our parts can reduce the harm caused by this disease and help us get back to a new normal that allows us to enjoy the things in life that we cherish. My name is Dr. Earl Chambers. I'm an epidemiologist and the director of the research in the Department of Family and Social Medicine at Albert Einstein College of Medicine and Montefiore Health System. I live in the Washington Heights neighborhood in Manhattan and have worked here at Einstein for about 14 years. In my role as director of research, I oversee the research in the department and provide resources for our scientists and doctors that are trying to answer at times very tough questions about how to improve the health of the communities we serve. As the name of our department implies, we are committed to healthcare for families and recognize the importance of social conditions that our patients live in that impacts their health. We know that healthcare doesn't start and stop at our clinic walls. The communities that our patients and employees live in and the access they have to the things they need to live a healthy life are the result of the neighborhoods they live in, the schools, the employment options that they have. We also understand that our patients' lived experiences shape their health, that racism and misogyny limit their options for health and well-being, that racist policies in housing, for example, determine where Black, Brown, and Indigenous residents live and the access they have to resources, that racial bias can limit their healthcare. This COVID-19 pandemic has shown us that our unequal social and economic structures enable disasters like this virus to affect some of our communities more than others, creating even more devastation for these already vulnerable communities. Over the last few years, we have seen so many examples of the cost of structural racism on the health of Black people. We must continue to expose these injustices and shed light on the costs of racism and sexism on all of us. As the great writer and activist James Baldwin said, "Not everything that is faced can be changed, but nothing can be changed until it is faced." So I stand here in solidarity with the people in our communities that advocate every day for a healthier Bronx, as a witness to your lived experience. I believe where and how you live matters to your health and the choices you have. And while our Bronx communities have many challenges that are important to understand, they are more than just where they rank on a health list of New York counties. They have strengths and assets that make them resilient and unique. We should emphasize those as well. The Bronx has the largest food distribution center in the United States at Hunts Point, bringing in food that feeds the nation. The Bronx has survived a devastating fire that burned down entire communities, but it still stands as an inspiration for many. It is the birthplace of hip hop. Famous artists, including Celia Cruz, Miles Davis, and Duke Ellington, are among those whose final resting place is in Bronx's Woodland Cemetery. The Bronx is also home to the New York Yankees. The Bronx has the largest park of any of the boroughs in Pelham Bay and is home to the New York Botanical Gardens. The Bronx Zoo is the largest of the city's New York City zoos and the largest metropolitan zoo in the US. But that's not all the Bronx is. What else is important about this borough? I would like for all of you to consider the strengths of the people and the culture of the Bronx, the things that make you most proud of your community that you wish people knew about and celebrated. At different points during tonight's program, we'll provide a website where you will find a call to action survey. There, I would ask that you share 1 or 2 words that describe what you believe is the Bronx's superpower. You can write as many 1 or 2 word descriptions as you want. We will compile what you write and share them with you later on. Now, I acknowledge that while technology has expanded our ability to reach many over far distances, it also limits access for some. I recognize that even being here virtually tonight to be a part of this conversation is not possible for all. So I also ask you all to take what you learn here and share it with others you know that were not able to join. Okay, I was asked to speak tonight about the role research plays in the lives of the communities we serve. To do that, I want to share a little bit about myself, or really about my grandmother, in the hopes that it will make the research I do make a little bit more sense. When I was young, maybe middle school or so, my grandmother came to live with us for a while. You see, my parents immigrated from the Caribbean island of Jamaica and settled just outside of Washington, D.C. in Maryland. At this time in her life, my grandmother was retired from her profession as a school teacher. I remember my grandmother as a very stern woman that loved me very much. She loved to play the piano, and she played beautifully, mostly songs and praise of worship to her Savior. By this time in her life, she had experienced many tragedies, as her husband had passed away, as well as her firstborn son. Many of the men in her life had died younger than they should have from health conditions that were preventable. My grandmother had diabetes most of her adult life. For as long as I knew her, she was managing this health condition. It was a part of her life and impacted everything she did. She would go for walks every day, and she was very careful about what she ate. She knew a healthy diet and exercise were important to managing her diabetes. That's not to say that she didn't eat things that she probably shouldn't have from time to time, but nobody's perfect. When she moved to live with us, she had to adjust to where we lived in order to keep her routine. It wasn't easy at first. Back in Jamaica, she could get to what she needed very easily: food, community, and her daily walks. In our neighborhood, she had to make adjustments. Walking to get food wasn't convenient. Getting to the market was farther away than she was able to manage, and required crossing busy highways, which made her very uncomfortable. And mind you, we lived in a middle-class neighborhood, but even so, she had barriers to getting what she needed. Even the best of intentions to choose healthy can be constrained by the options in your neighborhoods. My grandmother lived to be 99 years old. By the time she passed, now back in her home country, the diabetes had taken her sight, but she had seen so much by then. She met her grandchildren and even great-grandchildren. We should all be so fortunate. The story of my grandmother is a common story that many of you can probably relate to in some ways. Managing a health condition that requires regular medical care, living in homes with children and grandchildren, navigating a country unfamiliar to you and adjusting to cultural differences. My grandmother was very fortunate, but still had struggles that defined her. She had a stable place to live and family to support her when she came to live with us, but so many don't have that. She made healthy choices for herself and her family, but was often constrained by where she lived and what she had access to. Think about the neighborhoods you live in. How easy is it to access what you need to choose healthy options? What are the things that make it difficult to get to a doctor when you need one? We can build healthier communities together by advocating for what we need and using our collective voices to do so. In my work, I study how the lived experience of people in the communities that they live in shape their health. I study what much of you already know to be true, which is our health is determined to a large extent by the places we live, work, raise our families, and grow old in. The work I'm involved in looks more closely at how the health of communities are shaped by neighborhood conditions and affected by government policies. Our research shows that affordable housing is important to health. It stabilizes families and makes it easier for them to prioritize their health needs. The access to healthy food, the safety of your streets, the conditions and access to parks and playgrounds for your children to play in all affect health. And that our seniors need access to parks as well and walkable neighborhoods that make getting around safe. We also know that cycles of poverty that limit choices for generations of families are not of your own making, but reflect the cycle of injustice that disproportionately affect Black and Brown communities, as well as Indigenous communities. More than 16% of our Bronx community live with food insecurity. That's 1 out of every 6 homes not having enough food to feed their families. We all should have access to healthy food, affordable quality housing, safe neighborhoods, and access to quality healthcare. The number of people experiencing homelessness has risen during the pandemic. The lack of shelter is an important barrier to health. Through our homelessness fellowships here at Montefiore, we treat many patients experiencing homelessness, and our doctors know the challenges of treating the health needs of patients that are not in stable housing. There are programs that can help. Programs like Housing First has been shown to work to help patients experiencing homelessness get stable housing and place them in a better position to get healthcare they need. We can solve these issues. We have an obligation as a society to provide the resources that communities need so each of us can reach our health potential. Your decisions for your health are shaped by the actions within your communities, the options within your communities. And like many of you also know, sometimes, and perhaps many times, you have to fight for more or different options so that you can choose better for yourselves and your families. When you fight for clean air in your communities, it's because you know that exhaust from trucks and the highways that run through your communities are making your children's asthma worse. The research supports your concerns for the quality of your air. Right now, our medical students, scientists, and doctors are joining community-based efforts to do something about the truck and car fumes from the Cross Bronx Expressway that fill our air throughout the Bronx. The Bronx One Policy student group here at Einstein, teaming up with the community organization Loving the Bronx and others, have advocated for innovative designs that cover parts of the expressway, which can allow cars and trucks to continue travel underneath, but filter out harmful particles in the air, and also allow for open space on top that can be used for expanding parks and recreation space. There's a legacy of destroying communities of color in the United States for the sake of transportation progress. By capping the Cross Bronx Expressway, these communities can reclaim these spaces and use them for outdoor activity. Innovative designs like this can be a step towards undoing the injustices of the past that uprooted mostly communities of color in order to connect transportation arteries for the country. This is just one example of many, showing how communities are working with scientists, doctors, and students to shed light on community concerns. They work together to share their concerns with politicians, using research to support their efforts. It takes a unified approach for change. I remain hopeful that their efforts will be successful. There are so many others at Montefiore-Einstein doing great research in many different areas, like providing family planning options for women, expanding what works in treating opioid dependence, preventing diabetes and heart disease and complications from asthma, and of course, expanding what we know about COVID-19 and how to treat it. But this work cannot be done without the help of the people in the communities that share their needs and concerns to help shape the work we do. Through the rest of the program tonight, you will get your questions answered by my colleagues here at Montefiore-Einstein that are engaged in COVID-19 research, many in collaboration with all of you. While we are focusing tonight on COVID-19, we also know that other health conditions like diabetes and asthma, for example, have made communities like the Bronx more vulnerable to suffer from COVID-19 and remind us that we have more work to do in protecting our communities from these chronic diseases. And that is going to take all of us to shape our plan forward and fight for a healthy future. And with all that being said, and with all of you bearing with me for the last 15 minutes or so, I hand things back over to Zoe to introduce our panel of speakers for tonight.
Thank you so much, Dr. Chambers, for those inspirational words. As Dr. Chambers mentioned, we're dedicated to serving the community and really want to hear from you on how we can best engage with you. In addition to the clinical care that you all are familiar with that we provide, we offer various resources, including research opportunities, educational initiatives, and community events that we hope bring value and positively impact the community that we serve. As we plan ahead, your valuable input will help us understand how to better serve and reach the community. We will be putting a link, as Dr. Chambers mentioned, to a call to action survey in the Q&A box, where you can provide us feedback on how we can best serve you moving forward, including areas that you're interested in seeing more research in, or educational programs that you might be interested in learning from. Their survey should only take a few minutes to complete and will be available on our website after this event within a few days. We'll now be moving into our panel discussion, where our experts will be answering questions that you, the community, have provided to us, and we're going to do our best to address as many of them as we can today. I'm proud to welcome and introduce our expert panelists and want to thank them all for dedicating their time to this evening's event. So on our panel, we have Dr. Michelle Gong. Dr. Gong is the Chief of Critical Care Medicine, Chief of Department of Medicine in Pulmonology Medicine, and Professor of Epidemiology and Critical Care. We also have Dr. Carmen Asasi, who's Associate Professor of Epidemiology and Population Health, and also serves as Co-Director of Lifespan and Special Populations Core within the Institute of Clinical and Translational Research. Also on our panel, we have Dr. Carlos Rodriguez. He's the Director of Clinical Cardiology Research, also the Director of Cardiovascular Epidemiology, and Professor of Cardiology and Epidemiology. We also have Dr. Ann Ambrose. She's Director of Research and Associate Professor with the Department of Rehabilitation Medicine. Also on our panel today, we have Dr. Barry Zingman. He is the Medical Director of our AIDS Center here and also serves as Clinical Director of Infectious Diseases at the Moses Division of our hospital, and also is Professor of Infectious Diseases. Last but not least, we have Dr. Matthew Akiyama, who is Assistant Professor of General Internal Medicine and Infectious Diseases. So I am going to jump right into our questions today. I hope our panelists are ready. You're in the hot seat. So Dr. Zingman, the first question is for you. What about COVID-19 makes it different than the flu?
Thanks, Zoe, and thank you to Dr. Chambers and everybody who's here. Dr. Chambers, I could listen to you for another hour, so I hope to hear you again. So at its most fundamental, what differs between the germ that causes COVID-19 and the flu is that we have no immunity to it. This is virtually a brand new germ. It is that the world has not seen since the influenza pandemic of 1918. So we are completely susceptible to it if we come in contact with it. Second, the disease is overall worse than the flu. About 1 out of 6 people who get the COVID virus will be admitted to the hospital with severe infection. About 2 out of 100 people will die from it. That's 10 times higher than influenza. And then lastly, we have all the long-term symptoms that some people can develop after COVID-19. And that, in its scale and its scope, is vastly different than influenza.
Thank you. Dr. Akiyama, the next question is directed to you. What do we know about the long-term effects of COVID? So some people have experienced loss of smell or taste, general brain fog, as it's sometimes described, and overall just persistent cough. What can you tell us about the long-term effects of COVID?
Thanks, Zoe. So thanks so much to the organizers and to Dr. Chambers, as I agree with Dr. Zingman, amazing opening words. So as Dr. Zingman was alluding to, there are long-term effects of COVID for some people who are infected. And it's important to know that, we're 1 year into the pandemic, so we don't have all of the long-term effects that go beyond that year of experience we have so far. And that the long-term effects of COVID have more to do with the inflammation and injury that the infection causes than the virus itself. So these are changes that occur as a consequence of the infection, but are actually a long-term consequence of processes like inflammation. And they can lead to things like fatigue, trouble breathing, chest tightness, and cough, as Zoe mentioned. Less common symptoms are trouble smelling, headache, poor appetite, dizziness, things of that nature. And then other effects that can occur as a result of being in, for example, in the ICU are things like post-traumatic stress disorder, problems with memory, problems with concentration. So the effects are broad ranging and can be very debilitating to some people.
Thank you. Dr. Gong, the next question is directed to you. Why does COVID cause that shortness of breath or that heavy feeling in people's chests that they typically describe when it comes to COVID?
So thank you so much for this invitation to serve on this panel and to speak to our community who we dedicate all of our care and our efforts to. So the first thing is to understand actually COVID-19 does not cause shortness of breath in everyone. But unfortunately, a good percentage of patients do get shortness of breath. And that is because the virus starts to infect the cell lining in the lung. And it can do damage to the lung in two different ways. One is from the direct replication of the virus in the cells, which actually can cause some of these cells to become injured and die. Two is that the body's immune response to the virus can actually cause some of additional damage by having an intense inflammation. Any of these kind of injury to the lung, and it can be seen with any kind of pneumonia, can cause fluid to leak into the lung. It can cause cells to congregate in the lungs to try to fight the infection and fight the inflammation. All of which actually affects the person's ability to get oxygen, resulting in them feeling very short of breath, as well as that heaviness that you've described.
I see. Now you described damage to the lining of the lung and that injury. Is that injury repairable or is it kind of damaged for life at that point?
That's a great question and one that we are still figuring out. I would say that in the vast majority of patients, the lung will heal, okay? And they'll go back to normal function. What we're seeing, however, in a small subset of patients, the damage can be very, very long lasting. And we have now already some reports of patients that have enough scarring from COVID that they actually need a lung transplant. In addition, what we're seeing is that it can take a long time for some of these patients' lungs to get better. So even though we have had flu, as you have mentioned, and we've had pneumonias and we've treated those, we find that patients who have damage in the lungs from COVID will require time on a ventilator longer, and it takes them longer to come off of the ventilator and longer to feel better. And even if they don't get to the point where they need to be on a ventilator, many of these patients have shortness of breath for weeks after their COVID infection.
Thank you, Dr. Gong. Our next question is directed to Dr. Rodriguez. Are some groups at higher risk for COVID? And if so, can you tell us a little bit about those groups?
Sure, thanks, Zoe. I'd also like to thank the planning committee for this event and for making this event possible and inviting me to be a part of it. And definitely, I'd like to thank Earl for his words and his story and everything he's doing, which I appreciate. I'm totally aligned with. Thank you. To answer your question, persons with underlying medical conditions and persons who are older experience higher rates of COVID-19 that are severe. So they experience more infection, and they experience more infection that's severe. People in their 70s and 80s will have a much higher rate of COVID complications. And the particular groups, besides those who are older, persons with cardiovascular disease, specifically coronary artery disease, heart failure, cardiomyopathies, which is when the heart is weak or enlarged for some reason. People with type 2 diabetes, people with high blood pressure, hypertension. And now we see that morbid obesity is also a risk factor for COVID infection and complications. I guess the other group I'll add in, and Earl touched upon it, is that the data on race, ethnicity in underserved communities also show that Black and Latino communities are more likely to be affected from COVID infection, with more hospitalizations, more infections. And, a lot of that is because the pandemic has uncovered a lot of inequalities in society. Under-resourced communities have more of these underlying health conditions that I mentioned. Cardiovascular disease, high blood pressure, diabetes, obesity. There's also limited ability to social distance in, crowded places in the Bronx, crowded housing conditions, which I'm also familiar with. And also there's, it's just harder for underserved communities to have access to healthcare. So all these things have contributed to differential populations being more affected.
Thank you, Dr. Rodriguez. Dr. Ambrose, the next question is directed towards you. Will regular exercise reduce the risk of COVID or my COVID symptoms if I've been diagnosed?
Thank you very much for the invitation to join this panel and to be part of this event. I'm a rehabilitation physician, so I focus a lot on exercise. So physical exercise does reduce the impact of COVID if you get it. It does it by many mechanisms. One is you're fitter, your immunity is much better, and you're able to overcome COVID or any other disease. It also reduces the risk of having conditions like diabetes and obesity, things that make COVID worse. If you get COVID infections, one of the things that I'd like to take this opportunity to mention is that we do recommend that you don't go back to exercising immediately after getting the infection, to wait at least about 2 weeks. There's a significant number of patients who, even if they had mild COVID, may have some kind of inflammation in their heart or heart muscles that is undiagnosed. So we do recommend patients not to exercise at least 2 weeks after their symptoms resolve. If you're an athlete, we do recommend that you don't do any cardiovascular intensive training for at least about 3 months, and consult a sports medicine physician before you resume exercise at that level.
What would you say is the most important type of exercise that people should engage in to either reduce the impact of COVID, or that they should start on, as a different question, when they're resuming? What's a good way to kind of ramp up their activity?
We at this time are recommending a very low level physical activity. When you start exercising after having COVID, we suggest that you do not overexert yourself. So if you are starting to feel very exhausted during your exercise, or remain tired or fatigued for prolonged periods after whatever exercise you've done, you need to cut back. We are suggesting a very slow increase, starting with low level activities like just walking. and then increasing the speed at which you walk, the duration at which you walk, and then slowly adding breathing exercises is something that you should start with, and doing low aerobic exercises, nothing very strenuous.
I see. Thank you. Dr. Gong, the next question is directed to you. How can we be sure that the vaccine is safe when it's made so quickly? How do we know? What's the evidence?
So that is actually a question that's being asked by a lot of people. So the safety of the vaccine is determined by doing a study where they actually give the vaccine to many people and they measure how well does it protect the patients who got the vaccines compared to the patients who didn't in terms of coming down with new COVID. That's what's called a clinical trial, and it is the gold standard by which we figure out whether something is effective or not. And it's very systematic. They're very, very careful follow-up. They're constantly monitored to see if they come down with the infection and how severe the infection is. The vaccines have been tested in this way in multiple clinical trials that have involved tens and thousands of patients across the world. So this is a very large study in which they have been able to get very robust evidence about how well it works. In addition, okay, since the vaccine has come out, there has been additional other studies that have involved thousands of patients who have gotten the vaccine to examine the effectiveness. And all of the studies have been uniform in their findings. That one, the vaccines are effective, okay, upwards of 90+% effective in preventing especially the severe COVID infections that can lead to hospitalization. And two, the vaccines are safe. That is not to say actually that there's no reaction whatsoever that can be seen with vaccines. When you have the vaccines for so many millions and millions of people, you know, you're going to find some rare instances of events that you may hear about in the news. But they're rare. And in the context of a pandemic where the COVID virus is prevalent in the community, the danger of getting COVID and getting sick from that far exceeds the risk of any vaccine and the rare instances of some patients getting some complications. Now, people have some doubts about the vaccine, partly because it happened very quickly. But let me assure you that the rapidity by which the vaccines came out on the market is not because of any cutting of corners or short stacking or shortcutting of any methods. The reason it was so quick was because there was an unprecedented worldwide cooperation in terms of developing the vaccines, a partnership oftentimes between industry as well as universities, and as well like Oxford's, as well as actually the government. The United States alone poured in millions and millions of dollars to help these companies develop the vaccine. And then, unfortunately, because the COVID was so prevalent in our world and there were so many cases of patients developing COVID-19, enrollment into these trials and getting the patients in happened very rapidly. So the fact that actually the trials were quickly done is not a sign of any shortcuts. It is instead a sign of a worldwide unprecedented collaboration, urgency within the medical community to get at a vaccine as quickly as possible, and a sign of actually how bad the pandemic was in that we were able to enroll that many patients that quickly around the world into the trials to demonstrate the evidence that it works.
Thank you, Dr. Gong. That was very informative. Dr. Asasi, the next question is directed to you. You know, Dr. Gong just talked a lot about, getting lots of people into these trials to be able to get a result quickly. Why does it matter who participates in research in general or in this clinical trials related to COVID?
Thank you. Thank you for this question. This is a very good question, and thank you for the organizers and the invitation to this panel. So as Dr. Gong mentioned, clinical trials are a special type of research studies in which we test whether a medicine or a vaccine, works, in decreasing, in curing the disease or decreasing the symptoms, or in the case of the vaccine, whether it, works in the sense of decreasing the risk of infection and the complications of the vaccine, such as hospitalizations or death. We need to ensure that clinical trials enroll participants that represent who is at risk of the disease that we are talking about, that the vaccine or the medication is going to be tested and is going to be, in the future used for. And the reason we want to do that and make sure that there is diversity in the participation in research studies is because we want to make sure that the vaccine, in this case, works for everybody. And that also that there are not particular groups that may be more likely to have, more side effects than others. So for example, and we, in the case of the vaccines, we know that, older and younger individuals, their immune system may react differently. As people age, the immune system is not as good when they are younger. So that is the reason why we have to, test the effectiveness, whether the vaccine works in older and younger individuals to make sure that, we achieve the same effect. And the same, goes for participants of different racial and ethnic, groups. We need to make sure that the factors that influence the health of individuals from different racial or ethnic groups are no different in terms of the effects that a medication or a vaccines are going to affect. Like, for example, there may be some groups that are more likely to be, obese, so that they're more likely to have diabetes. And we want to make sure that all these underlying conditions don't create certain groups that in which some medications work or do not work, or that create more side effects. So that is the reason why we want wide diversity of people participating in clinical trials and in general research. So in the case of the vaccine, there was a big effort on trying to enroll in these clinical trials as diverse as possible, so that we know that the vaccines works for everybody.
Thank you so much. Dr. Zingman, the next question is directed towards you. How do we know that there are no long-term effects of the vaccine?
Yeah, it's a great question. So of course, we don't know absolutely, positively, that there are no long-term side effects of the vaccines. However, every other vaccine that's ever been developed, the side effects are short-term. So they virtually always occur in the first month or two after. So we have a long track record of developing vaccines that shows us that although we of course have to follow people for long term, it's extremely unlikely that there will be things occurring many months or years later that weren't picked up in the first few weeks.
Thank you, Dr. Zingman. Dr. Isasi, I want to come back to you just for a moment. Dr. Chambers, during his opening address, talked a lot about health disparities and access to healthcare and sort of what that looks like as far as the impact it has on the community. And one question that we've been asked is, do rich people or richer communities get different or better vaccines than poor communities? Can you talk to us a little bit about that?
Thank you. This is an excellent question. And we all know that there has been historically, profound inequality in access to healthcare, in access to best therapies, in the quality of therapies. And that has been not only in the United States, but worldwide. In this sense, people or groups with more resources, have better access to new therapies that work perhaps better than others. And there are many examples, when a new lipid lowering, like cholesterol lowering medication comes, the costs are, prohibited for individuals who don't have health insurance or that have suboptimal coverage, in terms of their insurance. So there's historical reasons to think about this unequal access to medications. Thankfully, this has not been the case for the vaccines in this country. The vaccines that have been approved so far and are being distributed in the country have very similar effects. So there are no communities that are receiving different type of vaccines that may work, that are inferior than others. And this is great. What we have been experiencing though is like there, despite efforts, there are differences in the uptake of the vaccines. For some communities, there has been, barriers or challenges in getting appointments, in getting the time to go and get vaccinated. But all the vaccines that have been approved so far in this country work the same, very similar to each other, and they're accessible for everybody.
Thank you, Dr. Sassi. The next question is directed towards Dr. Rodriguez. Can someone who gets the COVID vaccine get COVID-19 from the vaccine?
Thanks, Zoe, for this question. The vaccine cannot give you COVID. What it does do is that it revs up your immune system. It revs up your immune system to react and develop antibodies as if you were to have COVID. That way, preparing your body for that, real instance, real scenario in the future that you are exposed to the virus. Now, once you get the vaccine, as the immune system revs up, it can cause you to feel as if you're sick, because it's like your body is fighting. So that's why some of the most common symptoms people report by the vaccine are things like fatigue or headache or muscle pain or chills. But this is all just your body, again, revving up and preparing for that real future scenario of being exposed and having to fight actual COVID. And all of these feelings and symptoms are temporary. They occur somewhere between 2 and 4%. So 2 out of 100 or 4 out of 100 may get those symptoms. And they usually resolve within 24 to 48 hours. So it's not actual getting sick or getting COVID, but it's your body preparing for that fight in the future.
Thank you, Dr. Rodriguez. My next question is for Dr. Gong. Should someone get the vaccine if they had a reaction to another vaccine, like let's say the flu vaccine in a previous year?
So it's important to know that the vaccines that are made to fight against COVID are made very differently than the vaccines that were made in previous infections like the flu. Many of those older vaccines that we're used to, the flu, the measles, all that, are actually made by using eggs and to generate some of that viruses. So some of the components of the vaccines that exist in the flu vaccine are not at all present in the COVID vaccine. So the reactions that some people have had with the flu is not going to happen necessarily with the COVID vaccine because they're made differently. Having said that, though, I think it's also reasonable to talk to your doctors about what your reaction was to previous vaccines. It doesn't mean that you can't get it, but it might mean that actually if you were to get the COVID vaccine, they may choose to observe you a little longer than usual for other people. So in general, for anybody who gets a COVID vaccine, is generally observed for about 15 minutes to make sure you don't develop a reaction, everything is okay before you can go. For somebody who's had a previous reaction to a vaccine or severe allergies for whatever reason, it might be a little longer than that. So instead of 15 minutes, it may be something like 30 minutes. But it doesn't mean that you cannot get the COVID vaccine.
Now, Dr. Gang, you mentioned a 15-minute sort of observational period. Is that normal, or are you guys looking for something during that time?
So that's the routine for almost every patient who's getting the COVID vaccine. And again, that's just to make sure that, everybody's comfortable and there's no reaction to the vaccine. And the actual instances of reaction to the vaccine has been very rare. For a vast majority of these patients, 15 minutes is more than enough to know whether anything is going to happen. And for the vast majority of patients, nothing happens.
Thank you for that. Dr. Zingman, my next question is directed towards you. If someone's pregnant or breastfeeding or thinking about getting pregnant, should they get the vaccine?
Thanks. A lot of people are asking that question. And there is a lot of misunderstanding about that issue. First, let me just say that pregnant women are at increased risk of developing severe COVID. If you get COVID and you're pregnant, there's a greater chance that you're going to be hospitalized, a greater chance that you're going to be needing a ventilator, and a greater chance of dying from COVID. So it is particularly important for people who are pregnant to carefully weigh this decision about getting protected because they're susceptible to COVID for 9 months, and it can be much worse. So let me also just say it in a different way, is that the way these vaccines are delivered into the body and the way they work, there's no reason that they should be able to affect a pregnant woman particularly adversely, any different than other vaccines. The vaccine itself is injected into the muscle, goes into the muscle cells. It doesn't go anywhere from there. So it doesn't go to the placenta. It doesn't go into the rest of the body. It doesn't go to the unborn baby. The vaccine itself doesn't go anywhere. The good response to the vaccine, that does go everywhere because that's how you get protected against getting COVID. But the vaccine itself doesn't go anywhere. Okay, so we have every reason to believe that there should be no ill effects on a pregnant woman or her unborn child. Now, just about 2 weeks ago, the CDC reported results from 35,000 women in the United States who were pregnant and got the vaccines. What they showed was that there was no significant difference in side effects in the pregnant women. In fact, the women were a little bit more likely to get pain at the injection site, but actually less likely to have fever and chills and sweats and headache afterwards. In a little bit less than 1,000 of these people who delivered a baby, there were no significantly different outcomes in the babies than in other women who were pregnant who didn't get the shot. So it does seem like it is very likely to be very safe and very important for pregnant women to be protected.
Thank you, Dr. Zingman. Dr. Gong, the next question's coming back to you. If someone already had COVID and has antibodies, should they still get the vaccine, or are the antibodies good enough?
So that's an important question. So it's first important to understand that people who've had the COVID-19, there are reports that these patients can get COVID-19 again. Okay. It's not as common as people who've never had COVID before, but we do see it. It's also been found that the antibodies and your immune response do kind of fade after a certain amount of time. What we're seeing is that in patients who've had COVID-19, if they actually get the vaccine, there is a boosting of their immune response so that they're better able to recognize the COVID-19 virus if they were reintroduced to it somehow. And there's also evidence actually that it may give them some protection or added protection to potential variants that may have developed since the time that they got the infection and when the vaccine was developed with it. So it is still recommended that patients who've had COVID-19 before still receive a COVID-19 vaccine, as it may still protect them from future infections.
Thank you, Dr. Gong. Dr. Asasi, the next question is directed towards you. Has the vaccine been studied in children?
This is a very important question. Probably most of you have heard that as of yesterday, the FDA and the CDC had approved the vaccine for adolescents aged 12 to 15. So that means that people 12 and up can now get vaccinated. There are ongoing trials now for younger children. They started like around March or so of this year, but the results are not ready yet, and probably results are going to be ready in the fall. So we would expect that there would be approval also for using the vaccine in younger children.
Thank you. And so do we know that it's safe for adolescents?
Another good question. Yes. So the results of the studies that were conducted show that it's safe and effective. The trial enrolled like about 2,000 adolescents, between the ages of 12 and 15. Half of them received the vaccine, and the other half received placebo, so something that is not the vaccine but mimic that. And the results show that none of the adolescents who were vaccinated developed COVID, and about 16 of the adolescents who did not get the vaccine, got COVID, got infected with COVID. So that shows that the vaccine really had a very good protective effect. The good news also is that the side effects are no different to what has already been shown. So there are minor side effects similar to what people, adults are experiencing, in the sense of pain, in the area of injection. Some experience like fatigue, headache, things can last 1 to 3 days. So there are no more side effects or more severe side effects to what we already have shown for adults.
Okay, thank you. Dr. Rodriguez, the next question is for you. The Johnson & Johnson vaccine was halted because of this risk of blood clots. How bad is that risk compared to other medicines or other vaccines that we might be more familiar with?
Well, Zoe, this is a really important question, and I'll answer it, but I think that it bears getting additional opinion and input from others on our panel. So more than 7 million doses have been given of that J&J vaccine, and just 30 cases of blood clots have been identified, which makes it extremely, extremely rare. It's still important, but it shouldn't stop. It shouldn't stop someone. It shouldn't stop us from getting the vaccine. People are more likely to get a serious blood clot if they're infected with COVID-19 than they are from the vaccine to prevent the disease. And that's the benefit risk balance that we do as doctors all the time, where the benefits clearly outweigh the risk in this scenario. We learned that COVID can cause inflammation in the blood vessels. It can cause blood clots, and nearly a third of patients will have some type of thrombotic event. I guess if I compare it to another medicine, which as a cardiologist I use frequently, Eliquis, which is a blood thinner to prevent stroke and atrial fibrillation. So maybe 2 out of 3 out of 100 patients may develop some bleeding with the medicine. But without the medicine, 10 to 20 patients will develop a stroke. So the benefits clearly outweigh the risk. And I think that's the scenario here. But there are other vaccines out there that work a little differently and haven't been shown to have these thrombotic events. So I think the fact that these thrombotic events have gone on shouldn't really stop or avoid people from getting COVID vaccines if one feels that that's an issue that's preventing them. But again, Zoe, I think others in the panel can also weigh in.
Dr. Zingman, I know you were engaged in a vaccine trial here at Einstein and Montefiore. Do you have anything else to add to that?
Yeah, no, I just agree completely with Dr. Rodriguez and what he said. In anything we do, we're weighing the pros and the cons, the benefits and the risks. Getting into a car, walking across the street, we're actually weighing, whether you realize it or not, what could happen to us, and should we be doing this? And so it's no different when taking a medicine or getting a vaccine. The idea is that the benefits outweigh the risks. In this case, with that one vaccine, the risks are less than 1 out of 100,000 people get this side effect. That is overall a very acceptable risk for this side effect, given the tremendous benefits that the vaccine gives you.
Thank you for that. Dr. Ambrose, the next question is directed towards you. If a person's been vaccinated, are they still able to spread the virus to other people?
Well, the research suggests that if you are fully vaccinated, the chance of you getting an infection is very much lower, and even the chance of getting an asymptomatic infection is very, very low. And the ability to transmit it to someone else is extremely low. So vaccination does protect.
Thank you. Dr. Zingman, I want to just come back to you for a moment. So we've been talking a lot about vaccines in the context of other medicines that may be out there. But what is the real difference between how a regular vaccine, like things that we're used to, versus mRNA that we're seeing in this vaccine now? How are these vaccines different than what we're used to getting already?
Sure. Thank you. That's a little bit of a complicated question. So with most vaccines in the past, a little piece of the germ is given to the person. The body reacts to that little piece. It's not a live virus. The body reacts to that little piece. So the body has an immune response. If you actually get in contact with the full germ, you're ready for it. Okay. The little piece is produced by genetic material, what's called mRNA. So an alternative way to vaccinate somebody, one way is that you could give them the spike protein on the surface of the virus, or you could give them the genetic material that actually makes that spike protein. And it appears that giving that small amount of genetic material into the muscle seems to produce a tremendous amount and a really robust, a really strong immune response that highly protects people against it. So far, better than any other way of vaccinating people against COVID. And another advantage as well is that that little bit of genetic material that's being injected into the muscle, it goes away within hours. It just dissolves, goes away. It's not permanent, doesn't last, doesn't keep affecting the muscle. It goes away. So you get a tremendous jolt of the protein that the virus has, and then you respond to it and the vaccine actually goes away. So you're muted.
Sorry, Dr. Akiyama, the next question is directed towards you. Can you get one shot of the Moderna vaccine and one shot of Pfizer? If yes or no, and if so, why not?
So it is perfectly acceptable to get one dose, and recent studies have actually shown that there's quite good protection with one dose and not necessarily getting the full vaccine series for Pfizer and Moderna. There's a study in Israel recently that showed effectiveness rates of in the 80% range with one dose of the Pfizer vaccine, for example. And other studies are starting to show that the effectiveness of one dose versus two may be in the order of 60 to 80 or 90%, even that high. There are very good systems in place to be able to get both vaccines. So if you get the Pfizer or the Moderna vaccine, there are systems in place to be recalled. And that's the way that the vaccines were studied. So that is the way they should be obtained. But if something were to happen and the patient weren't able to get the second vaccine, they can rest assured that one dose is very effective in protecting them from the COVID infection.
So could I get one dose of Pfizer and one dose of Moderna?
It isn't recommended, but it is acceptable if that is the only option that the person has. If that's what they're being offered, it's acceptable to sort of mix and match the two. That is not typically the way that they're administered, and usually the person who gets one dose of one will be recalled for the same dose of, or a second dose of the same vaccine. But it is okay to get one and then the other. That will probably produce a similar response to getting two of the same vaccine.
So one question that we got a lot from the community was, is one vaccine better than another? Can you talk to us a little bit about that?
So the vaccines have shown different effectiveness in terms of preventing the endpoints that they studied. Most often these vaccines are studying prevention of severe COVID, resulting in hospitalization or even death. And so there are differences in the effectiveness in reaching these endpoints in these clinical trials that we've been discussing. But what we really want to put out there is that all of the vaccines are extremely effective. And this is a matter of sort of a race against time to get as many people as we can vaccinated. So we are encouraging people to get the first vaccine that is available to them because they all are extremely, extremely effective.
Thank you. Dr. Gang, I know we talked a little bit about this before related to the antibodies we have if we've already gotten COVID. So does the vaccine itself wipe out those antibodies that our body already works so hard to build? Can you talk to us about that?
Sure. So to understand actually how a vaccine and how antibodies and the immune response work against COVID, let me try to have an analogy. Okay. So if you were to train a dog to sniff out bombs, a dog is not going to recognize with the smell of a bomb right off the bat without any kind of recognition, any kind of previous exposure to that smell, right? So to get the dog to recognize the smell of a bomb and to find it, you have to train him by having him recognize something that smells like a bomb and then to find it. Similarly, if somebody has never had COVID-19 before, when they get it, the body is not necessarily going to recognize it and have an immune response against it. What a vaccine does is that it trains the body to recognize that as an infection, and it gives the body a chance and time to get trained in a natural way. The antibodies that are produced is no different than the antibodies that the body might be producing for another infection that they get, without a vaccine. But what happens then is several folds. Once you have the vaccine, or if you have the first infection, then you may have generated antibodies that help more rapidly recognize COVID if you were to get exposed to COVID again. But understand, though, that it is natural for antibodies in the body to eventually come down the further and further away that you have from the infection. Now, when it comes down, it doesn't mean that the body has stopped recognizing it. And it doesn't mean that the antibodies are completely gone and never to be found. It's just that it is down at a level because they haven't needed to see it in a while. But that if you were to reintroduce the infection, or the body will be able to recognize it again, and then you'll see the immune response kick back in and say, wait, we've seen this before, we know how to fight against it. Similarly, actually, when a person who's had COVID-19 already and they get a vaccine, even if they get it like months and months later when the antibody level from their first infection has come down, it doesn't eradicate those antibodies. What it might do is help the body create new antibodies that recognize the COVID-19 even better, or depending on actually what type of antibodies the patient already had, is to reduce and retrain the body and say, oh, we recognize this. And we recognize this and we know how to respond to it.
Thank you for that. Dr. Akiyama, the next question is directed to you. When does full protection from the vaccine go into effect? Do we know that?
So to follow up on that initial question on one dose being sufficient, we do know that even in the first week after the vaccine, that there is a pretty significant degree of protection. But in order to achieve the full response, we're counseling that people should wait 2 weeks after their full vaccine series to have the benefit of the full response. But even in the period following the vaccine and beyond about a week, we are seeing from studies that there is a significant degree of protection.
And so can someone get COVID in between these doses?
It is possible. We are seeing people who are getting infected after their first dose, for example. That is a more common instance than people getting the infection after getting a full vaccine series of both doses, but it does happen that people do get infected after the first dose.
Thank you. Dr. Zingman, the next question is coming to you. Will this vaccine that we currently have, or the vaccines that we currently have, protect us against these new strains of COVID that are popping up? And do you think that booster vaccines are going to be necessary?
Yeah, this is some of the questions that everybody's asking right now. So what it appears is that the current vaccines actually give immunity to many of the variants that are circulating. They actually give very significant immunity to the variants. Now, some of these variants are a little bit tougher than other ones. So there's one that originated in South Africa, one that originated in Brazil, that are a little tougher, that is challenging all of the vaccines. But at least for the most common ones that are the variants that are circulating in the United States, the current vaccines work very well against them. And there really isn't a significant decrease in their ability to work. Now, if some of those tougher variants of the virus start to come into the United States and start to circulate in other places, there may need to be additional doses of the vaccine or variant versions of the vaccine to be able to either boost the initial response by giving another dose or boost it to a new type of the virus. So we don't know yet that boosters are going to be needed, but it does seem like it's very likely, at least if COVID keeps circulating around the world, and if we keep getting waves of infection, the virus naturally changes over time. It naturally mutates, and as was mentioned by Dr. Gong before, it is certainly possible that our immune response to the vaccine that you got this year may go down as well over time. So boosters may be needed for a couple of reasons, and we think it's likely that boosters of one kind or another will be needed.
So Dr. Gong did talk about our natural antibodies, how they sort of taper off over time. And you just alluded to sort of this vaccine effect potentially also declining over time. How long, all these variants aside, right, can we anticipate that this will work for us? Do we know? How long does the effect last?
Sorry, was that to me?
That was to you, I'm sorry.
Oh, okay, sorry. Oh, sorry. You mentioned Dr. Gong's name. I thought it was her. We don't know yet. So the vaccines just haven't been out for long enough, and it's not enough to just know from the first 100 or 500 or 1,000 people who got it last spring. We need to know it on a large scale from the tens of thousands of people who were in the major large clinical trials that went on last summer and into the fall and into the winter. So we do know so far from each of the vaccine studies that have been able to follow large numbers of people for at least 6 months that the immunity lasts at least 6 months and is only slightly lower at 6 months. From that, we would predict that they should last at least a year. But we are still learning about how do you even measure the immunity to these vaccines. There may be a couple of different ways to measure whether or not the person remains protected from these vaccines. And we are learning how to best measure that, because it may be that Dr. Gong mentioned antibodies. Antibodies seem to be an important way of protection after the vaccine, but they may not be the only way that we're protected from the vaccine. It may also be other cells in the body that protect us. And so we actually need to be able to try to measure those things over time and really assess, what is the best way to measure whether or not somebody's still protected against the virus, whether it's after getting a vaccine or after getting COVID. And this is, and just going on this theme, this is a very, very important question for all the people who may be at higher chance of not responding as well to the vaccine. So all the people who are immune compromised from medications or treatments, and they might have a lesser response to the vaccine. We really need to know whether or not they are immune now or not, whether or not they need an additional booster or a booster sooner, for example. So we are still learning a tremendous amount about the immunity to the virus, immunity from the vaccine or COVID, and then how to use that information to decide on boosters or other methods.
Thank you for that. Dr. Akiyama, my next question's for you, and I might go to a few of you other panelists as well to answer this question, but if people express that they feel safe wearing masks, washing hands, social distancing, and therefore don't feel like they need to get a vaccine, what would you say to those people?
So first of all, I would say thank you and congratulate them for staying safe and washing their hands and staying distance. Those are all really critical measures that we saw were the only thing we had in the early phases of the pandemic last year. This is all about barriers and improving the barriers between us and other people that will keep ourselves, but also the people around us and the people in our community safe. And the vaccine is yet one more barrier that we can take in order to reduce the risk of us getting sick personally, but also the risk of transmission to other people. And so while wearing masks, washing hands, social distancing are all very important, the vaccine is yet another strategy we can use to raise those barriers. As some have mentioned on the panel, the new variants that we are seeing are more infectious. So despite the use of masks, the new variants can be more infectious and can infect people who may be wearing masks. So again, the vaccine is yet another level of protection against these new variants. So I think that's what I would say to those people.
So Dr. Gang, do you think these measures that we're doing, that we've learned so well and have been kind of force of habit now in some ways and built into our routines around washing our hands and not necessarily wearing a mask, but just distancing in general, are these things that maybe we should consider keeping as part of our lives moving forward to improve the overall health of our community?
So that's an interesting question and one that's being asked. Let's think about it from multiple different levels, right? I think one thing that is clear from this pandemic and from the studies that have been done is that these barriers, the mask, the social distancing, hand washing, they do work, okay? They do work in decreasing transmission of the virus. So that means that actually for future pandemics, we will learn that this is an effective way to try to keep it in curb. So that is true, whether it be another coronavirus pandemic or really bad flu pandemic. Respiratory viruses that causes infection like COVID-19 would also be amenable to such interventions to decrease its transmission. There are many of my colleagues who actually have talked about doing this routinely because they haven't had a cold in this past year because they've been wearing masks and have had social distancing. Now, having said that, though, that it's been well known that if you're immunocompromised, it's always been recommended that if you're immunocompromised and you're susceptible, then wearing masks in situations where you are at higher risk of coming down with a infection may be protective. And I don't see that changing in any way. I think that's going to continue. What may also happen is that when people are known now to have to be sick, if you know that you have illness, would we also wear masks ourselves because it might protect our neighbors and our peers from catching our infection? And we'll see.
Thank you for that. Dr. Asasi, this next question is directed towards you. Are people of color more at risk for, bad side effects from COVID in general?
I don't think there's data that supports that. I think the risk of getting COVID and getting severe COVID is much more important than any differences in vaccine side effects. But there's no reports of certain groups having excess side effects.
Thank you for that. So I'm going to quickly check on the chat and see if we have any additional questions in there. Looks like that has been addressed already. So what I'd like to do is just kind of go around the room quickly. You know, you all have been working so diligently, whether you're on the research end or the clinical side or both during this whole COVID pandemic and well before that. And what I want to just ask you all is, what's one takeaway from the COVID experience that you hope the community learns? And Dr. Rodriguez, we'll kick it off with you. But if there's one thing, what would you hope everyone takes away?
I guess, yeah, the answer is has some layers to me, because, you know, I'm glad, as I'm sure we all are, that the number of cases seem to be going down, and importantly, the number of COVID deaths seem to be going down. But I think we're all significantly traumatized from all the chaos that took place a year ago as we bravely addressed this pandemic. You know, and that stays with me. So, you know, I served as an Army medic for the National Guard for 9 years, and I can tell you that what we were seeing in the hospital, it seemed like a war zone. You know, just like the war training exercises that I've experienced with people sick, in pain, dying, and you know, neither the patient or the provider clearly knew what was going on, as we were just learning about this horrible disease. I think as a medical community, we responded bravely to treat the community. In cardiology, I saw cath labs and operating rooms become COVID ICUs. And I think everyone across Einstein-Monte had an all hands on deck approach, where regardless of who you were and what position you had or what seniority you carried, everyone was available to help around the clock. Even, you know, we were even treating patients without PPE. I remember doing this and putting my lives, you know, and this, not just me, I mean, all of us, putting our own lives at risk and our family lives at risk to take care of other patients and to take care of our community. So, you know, those are lessons learned that we don't want to go back to. During that time, we also learned that how COVID affects the heart, and you know, how COVID causes injury to the heart. We saw that on echocardiograms. There's cardiac abnormalities. COVID can infect the heart directly. It can cause cardiac injury through the inflammation that the COVID infection causes. So heart damage was relatively common. Actually, one study showed the effects of a scar in the heart in 30 to 50% of patients who've had COVID, more than 30 days after the acute infection. So we also saw abnormal ECGs in people with COVID. So, you know, as a cardiologist, the takeaway is how COVID affects the heart, how it's important to appreciate good health for everyone, to prevent cardiovascular disease, to make sure your blood pressure, cholesterol, and diabetes are controlled, and to take these vaccines, because they're our best chance to not go back to what we had before. They're our chance to really prevent infection, not just for ourselves, but for others in our community. And even if we're not vulnerable, there's others who are vulnerable, more vulnerable than us. So we can protect, again, not just ourselves, but everyone in our community by taking these vaccines.
Thank you for your insights, Dr. Rodriguez. Dr. Ambrose, what is one takeaway from the COVID experience that you hope the community learns?
this has been an extremely difficult 18 months or so for all of us in both the medical field and among the public. One takeaway that I would suggest is, trying to maintain your health, exercising regularly, so that if if you get COVID, then your chances of getting a serious illness is very much reduced. If you get COVID, mobilization, breathing exercises, and gentle exercises right from the very beginning is showing that is shown to reduce the severity of the disease and the mortality of the disease. So being active, being sensible in how much activity you do seems to help reduce mortality.
Thank you for that. Dr. Asasi, what is one takeaway from your side from the COVID experience that you hope the community learns?
Thank you for that question. As the as the virus came to the United States, I remember texting with some of my colleagues and friends, thinking about that this is going to be a disaster for our communities of color, anticipating that soon would be a problem for all the communities that are low resource, that have been neglected from policies and healthcare, and as it happened. And so one of the things that is going to be in the discourse now is that this pandemic has been instrumental to bring to everybody's attention phrases like structural racism, that healthcare is not equal in our society, and that we have neglected the most vulnerable in our population, people in the Bronx, people of color, people at the end who kept us safe and fed, but nevertheless experience the worst of the pandemic. So I hope, like, the lesson here is that government and community have to work together. And on the other hand, on a more positive aspect is that, once again, the strength comes from the community, and this has been shown here in the Bronx, in New York in general. The value of community cohesion, the value of what we can do together. When we were instructed to go home, to stay safe, to wear a mask, we did. And that helped reduce, the risk and protect people who were frontliners, not only the medical profession, nurses, medical technicians, and the whole healthcare personnel, but also the frontline communities that we tend to ignore, our taxi drivers, our food delivery, friends, our people working in grocery stores. So, when we act together, we get results. And I hope like this is, a take-home message.
Thank you so much for that, Carmen. Dr. Akiyama, what would be your one takeaway from the COVID experience that you hope the community learns?
I'd like to mirror what Dr. Sasi said in terms of equity and access to healthcare. I think we've seen really stark gradients in that, and it's been very troubling to see. I work closely with people who are involved with the criminal justice system and who are incarcerated, and we've seen situations where legal action has been needed to be taken in order to provide access to life-saving medicines and vaccines, and those types of gradients and who gets access to medications can't go on in 2021. We are seeing progress made, but and I think in some ways COVID has helped us advance health equity, but clearly much more needs to be done. And the second thing I'd say is teamwork. We saw unprecedented teamwork during the COVID pandemic. I think you can see on this panel, there's an interdisciplinary group of people everyone in the hospitals caring for people, our patients during the COVID pandemic really came together, and that was really inspiring to see.
Thank you for your words, Dr. Akiyama. Dr. Zingman, what would be your main takeaway from this COVID experience that you hope the community learns?
There are many, but if I had to just say one, I would just say that I would just say that this pandemic has shown us that infections know no barriers, and we are one world. If anybody ever had any doubt, that doubt should be gone. We are one world. We are one city, one country, one world. Everything that we do affects our neighbors, and that affects everybody else. And in addition, the way we will fight this pandemic is with a one world approach. We are not going to get through this well if there are more Indias, if there are more areas of the world where there are inadequate vaccinations rates, inadequate medical care, the virus is able to grow. We are not going to be able to get through this unless we view every person, every country, every area as equally valuable in the fight against the pandemic. Yeah, we're all related. That's what I'll. And Dr. Chambers mentioned smog is one example. Absolutely. The things we do affect everybody around us. We need to be thinking more about these effects.
So, well, that was so insightful. What would your second takeaway be to the community? You definitely have one ready.
The well is dry. No. What would be?
We can come back to you.
Trust us. I would just say trust us. And we in public health, infectious diseases, medicine, we don't know everything. We don't get it right from the very beginning necessarily, but we have your and our interests in heart, and so we hope you'll trust us. We hope you'll take medicines, take precautions, take vaccines. We hope you'll work with us.
It's so interesting because, I think a lot of the fear just in how quickly this unfolded was how guidelines changed, how treatments changed. And really what this pandemic did is put a magnifying glass on things that are going on behind the scenes all the time for us that typically don't happen this quickly, but it's not unprecedented for guidelines to change as new information comes about. So can you talk a little bit about that?
So a number of people in this group have been involved in guidelines for COVID, doing research, publishing that research, and the approach just has to be to gather in all the latest information and just use it the best we can, and then guide practice progressively over time. We're just not at a point in this pandemic where we're 10 years into it and we know exactly, all things about it. So virtually every day there's new information that comes out, and sometimes that can be confusing and seem contradictory. But as long as we're, honest and dealing with the information that comes out and responding to it, then we'll get there. So yeah, and that's what guidelines reflect that. So treatment approaches change over time as we learn new things.
Thank you so much for that, and you're off the hook. Dr. Gong, what is one takeaway from the COVID experience you hope the community learns?
So I think my takeaway as the last person is really the theme that everybody has mentioned so far. So one thing that I really do hope we as a take away from is that we're all interconnected. And that means we're all dependent on each other, both for our response to things like COVID-19, but also our downfall and our responsibility to take care of those of us, especially among those who are most vulnerable, right? You heard from Dr. Rodriguez that we could not have responded to this pandemic and to this crisis unless we had all acted together to bring in the manpower, the smarts, the brains to try to fight against what was happening. We've also heard from Dr. Sassian and Dr. Ambrose and Dr. Kima and Dr. Zingman about the importance of this individual responsibility to protect ourselves and each other by wearing masks and quarantining and trying to be able to take those personal sacrifices for the public good, for the public health. And we also actually have heard how our shortcomings in protecting those who are most vulnerable meant that we have positioned them to take the greatest burden during this crisis and to be most affected. We also have learned actually that for us to deliver the right care, to have the right response in medicine, you know, being a doctor is not enough. We actually need the support, the leadership of the government, our peers, our patients, our communities, because we can only do so much, but the pandemic is a public health crisis. Public health has public inherently in it because it does involve everyone in the community, not only in the fact that they can get sick from it, but also in the fact that they could have a role in helping protect each other from the pandemic getting worse. And, you know, I hope, you know, that we remember what has happened. I hope that the lives that we have lost are not lost in vain, because we owe it to all the patients who got sick, all the family members who have lost loved ones, that we have a responsibility to each other.
Thank you so much. Dr. Chambers, I want to come back to you. I know you're not part of our panel, but what's one takeaway from your side from the COVID experience that you hope the community learns?
Wow. So, you know, I've been listening like intently on everything and really trying to kind of, you know, take it all in. And, you know, I had a recent conversation with a neighbor of mine about getting the COVID-19 vaccine. He's in his late 60s and lives in a multi-generational home with his family. He has underlying conditions, and as far as he knows, has not had COVID-19. And despite my best efforts, I was unsuccessful in convincing him it was a good idea to get the vaccine. So I'm thankful for the work of our panelists and the information they shared tonight, so I can go home with better strategies in the future to try to talk to him about moving him closer and closer towards that goal of getting the vaccine. Thank you, Dr. Zingman, for clarifying how COVID-19 is different than the seasonal flu. That's a question I hear a lot. Dr. Sassi's points about why representation matters in clinical trials also resonated with me. It's very helpful sort of clarifying what is known about the safety of the vaccine in pregnant women and in children. So thank you for that information as well. My oldest child is 13 years old and he is getting his COVID-19 vaccine today, not far away from where we live. He's not thrilled about that, but you know, that's the case with all the things that he's asked to do these days. So that's no different. Doctors Gong and Rodriguez have been giving us a lot to consider when thinking about underlying conditions and the long-term consequences of the virus, and under what circumstances we should get the COVID-19 vaccine. So Dr. Akiyama and Ambrose, you know, have given us important information about what symptoms to expect when getting the vaccine. There's a lot to consider here. So thank you all for helping us understand a bit more about these issues and the risk benefit of getting the vaccine versus getting COVID or spreading the virus to others. So now at the beginning of the program, I asked all of you to think about your community strengths and assets. Here's what you came up with. Let's reflect on these community assets and keep them front and center. You'll have many opportunities to share your thoughts with us. As I mentioned earlier, We will send you a call to action survey where you can share your thoughts and concerns with us. We will compile all of these responses and display them on the Office of Clinical Trials webpage, I believe. So in closing, I want to leave you all with 3 takeaway points. First, the research we do cannot be done without the communities we serve and the people who trust us to do the best we can to help them stay healthy for their families and loved ones. We need your help to better understand your health needs. We need to continue to work collaboratively to understand how science can work for the people. What are the things that concern you most about your health? How can we work with your communities to promote health? Let us know. Second, this past year has been difficult. Give yourselves a break. Try to find some time to breathe. You need it. The trauma of the past year is very real and can be exhausting. Pay attention to your own health and seek out help if you need it. And third, last but not least, please go and get your COVID-19 vaccine. It gets us all a step closer to moving past this pandemic. In the link on the slide, you can go review all of what we discussed tonight. You can contact us so we can continue this work together. So thank you to the Institute for Clinical and Translational Research and the Office of Government and Community Relations for sponsoring this event. And of course, a big thank you to all of you out there for joining us tonight. So I'm gonna sign off. Good night and stay safe.
Thank you all so much for joining. We hope to hear a lot from you and to continue this partnership. So thank you all and have a great night.